And we ask that you please do remain muted during the presentation just to keep things clean and moving along. And do communicate with us in the chat. It is available to myself and any co-hosts I have. So as we know, the COVID-19 pandemic presented a lot of obstacles and forced us to change a lot of things in the way we lived our lives these last couple of years. Cancer health disparities research is no exception. Our three panelists are experts in cancer health disparities research and have graciously agreed to share their challenges and their solutions to those challenges today. Allow me to introduce Dr. Rebecca Palacios, a professor of public health and researcher at New Mexico State University. Dr. Lorna McNeill, professor and chair of the Department of Health Disparities Research at the University of Texas MD Anderson Cancer Center. And Dr. Kelly Glazer Barron, tenured associate professor in the Division of Public Health in the Department of Family and Preventive Medicine at the University of Utah. We will begin today's presentation with a brief talk from each of our speakers and then proceed to a question and answer portion for the panel. And as I mentioned before, please feel free to enter any questions you have in the chat throughout the presentations. And I will collect them and we'll get to as many as we can during the Q&A. We're going to start with Dr. Rebecca Palacios today. And as I mentioned, she's a health psychologist and professor of public health at New Mexico State University. Dr. Palacios has 20 years of experience conducting public health research along the US-Mexico border. Her work in the past 8 years has primarily focused on developing culturally relevant cancer education to address cancer health disparities in the border Hispanic population. Most recently, her research has assessed the needs and communication patterns of Hispanic mothers diagnosed with cancer in their school-age children. Currently, Dr. Palacios is testing the efficacy of Conexiones, which will be a cancer education program for diagnosed Hispanic mothers in the first clinical trial at NMSU. Dr. Palacios, I will hand the stage over to you.
Thank you, Amy. So let me see. Are you able to see my screen?
Yes, we can.
Okay. Okay, thank you. Thanks again for inviting me to share our experiences in conducting our clinical trial. It's been quite a challenge doing this during the pandemic. And so basically, as you stated, we're testing the efficacy of the culturally adapted Conexiones program, which is a cancer parenting education program for Hispanic mothers diagnosed with cancer. And just up front, I'd like to share the sponsorship of this research. We were funded through a U54 National Cancer Institute grant supporting the NMSU Fred Hutch Partnership for the advancement of cancer research. Given that the pandemic really threw a monkey wrench in our completing our clinical trial, our Office of the Vice President for Research at New Mexico State University provided gap funds to extend the clinical trial for an additional year, as did our Public Health Sciences Department through their contract with the New Mexico Department of Health. So first, I'd like to share a little bit of background as to what motivates us to work with this particular population. And so we know that mothers diagnosed with cancer may experience high levels of depression and anxiety. They may feel that the treatment and depression associated with their cancer leaves them physically and emotionally unavailable for their children. They're often not sure what to tell their children about the cancer or how to support their children in coping with the maternal cancer. In our own qualitative research with Hispanic mothers who had been diagnosed with cancer, the mothers shared their struggles with us. Here we see one mom sharing, not being able to hold on to that one thing I wanted to, the one thing that made me feel normal, I couldn't do. And that was really hard. And she was referring to being a mom to her children. Another mom stated, a lot of times I would drive to Albuquerque by myself and I would have a lot of these appointments by myself. So she was residing in the border region in the Las Cruces region and having to travel to Albuquerque for her treatments, as the border region is medically underserved and there's not a lot of specialists to address all types of cancers. And then there's another one, another mom stated, they always say it can come back, but even harder, stronger. And this is a recurrent fear among diagnosed Hispanic mothers that the cancer will be recurrent. Another mom, and this was also a common theme that came out, the mom shared, the most difficult part was definitely not knowing how to tell your kids. How do I explain this to him? And she was referring to her young child. On the other side, the children of mothers diagnosed with cancer may draw their own conclusions about cancer and their mom's behavior, and oftentimes incorrectly. And many of these children fear their mothers will die from the cancer. In our own work, the Hispanic mothers reported on their children's distress. One stated, they get sad because sometimes I can't do stuff with them and they don't know why, and I tell them why and they still don't understand. Another one said, if I get a cold, she's freaked out, referring to her daughter. Mom, are you going to the hospital? Now she's worried all the time. Another mom reported, the first time I had a follow-up scan and told her, they called us from the school to pick her up because she was throwing up because she was so anxious. She said they were going to tell me I had cancer again. And then finally, the big one and a common experience among the children, one stated, Mommy, I'm scared. Mommy, are you going to die? Okay, so you can see the distress that both the moms and the children are experiencing. So our goal was to develop an evidence-based cancer parenting program to offer support in managing cancer-related distress, both for the Hispanic mothers and their children. So we identified this evidence-based program that had been validated with non-Hispanic white women. It was developed by Dr. Frances Marcus Lewis, who is my collaborator on this clinical trial. She developed the Enhancing Connections program, which was a cancer parenting program designed to address communication and parenting issues around the topic of cancer, and also to improve emotional and behavioral adjustment in both the mother and the child. So in a clinical trial with diagnosed non-Hispanic white mothers of middle to upper socioeconomic status, she found that the Enhancing Connections program was effective in decreasing maternal depressed mood and anxiety, improving parenting quality skills and self-efficacy, and also in improving children's behavioral emotional adjustment to maternal cancer. So we worked very closely with Dr. Lewis to culturally adapt this program for Hispanic mothers on the US-Mexico border. And we renamed the program Conexiones. So we conducted qualitative interviews with Hispanic mothers to inform our adaptation process. We not only adapted for Hispanic mothers, but for Hispanic mothers who were possibly of low to middle socioeconomic status and who were residing in an underserved region like the US-Mexico border. We then, once we adapted it, we had the community of Hispanic mothers reevaluate the program, and they provided additional information to further refine the program. We then conducted a pilot study and found that the Conexiones program showed significant improvement in maternal depressed mood, parenting self-efficacy, and parenting quality. It also tended to show significant improvement to our children's anxious, depressed mood. So now we're conducting the Taking Time to Connect clinical trial for Hispanic mothers diagnosed with cancer. Participants are randomly assigned to one of two cancer education programs, either Conexiones or the Taking Time to program, which is based on an NCI cancer booklet. We want to know which is more effective in helping Hispanic mothers and their children cope with the cancer. So eligibility included being a Hispanic woman diagnosed with cancer in early stages of cancer in the last 2 years, while having a child, parenting a child 5 to 17 years old, and residing in either New Mexico or Texas. And we recruited participants from several clinical sites and also through a community health worker incentive program and through word of mouth. And the process included scheduling moms at a time that was convenient for them to participate, All assessments, all education sessions were done by telephone, so they could participate from the comfort of their own home. They could participate in English or Spanish, and participants received gift cards for each education and assessment they completed, as well as a cancer resource directory. So these were our primary outcome measures: depressed mood and anxiety in the mom, parenting skills and parenting self-efficacy and quality in the mom, and as well as the child's behavioral checklist, which assess behavioral and emotional problems in the child, as well as anxiety and depression. Okay, so we start the clinical trial and then the pandemic hits. We were just a few months into it, and now we were dealing with a pandemic. So you can see the stress that the mom and their children are already experiencing, and now we're dealing with the pandemic. So we encountered all of these obstacles, and I'm going to go through each of them very briefly. So first, we were concerned with patient confidentiality, as we were now working remotely from our own homes. So all staff members were in their own home, and we were still dealing with cancer patients and having to protect their information. So we had to revise our protocols for protecting their confidentiality. We had to beef up security on all of our home computers. We had to, we utilized a HIPAA compliant Dropbox to store all of our data safely. And then we also had to engage in revisions of several IRB protocols. We also had to be concerned about our team cohesion. How were we coordinating our efforts, and how were our staff members doing in terms of their own personal well-being during the pandemic? So the adjustments we made: first, we had to purchase and deliver equipment and supplies to all team members' homes. Team members had to report daily productivity to our program manager. And then we revised our team meetings to include call openings that allowed for connecting and checking in with our staff. So our call openings included like sharing our self-care techniques and also sharing gratitude for things that were going well in our lives. And then we also, again, needed to check in regularly on the needs for working from home. So another big problem that we encountered during the pandemic was the potential confound of our study outcomes, as our primary outcomes in our study included maternal anxiety and depression, as well as child behavioral and mood problems, which could be or were being impacted by the pandemic for most people, right? And so we had to include measures so that we could control for some of this in our clinical trials. So through the CDC website, we identified the impact of the COVID-19 pandemic and cancer survivors questionnaire, which assessed anxiety and depression in the mom, but as well, it also assessed a variety of other disruptions that could contribute to anxiety and depression in the mom as a result of the COVID-19 pandemic. We encountered recruitment barriers following the pandemic, as most of the clinical sites were so overwhelmed with trying to control infection, especially when you're dealing with a cancer population, and then having to implement their own new protocols and converting to telehealth appointments. So this made it very difficult for them to spare any time to try to identify participants for our study to refer to our study. Our adjustments included purchasing a telephone sample of Hispanic women of parenting age in the border region. And what we did was mail out letters advertising our study and saying, if there's anybody in the household who fits the eligibility criteria and would be interested in participating, they could contact us with the information provided in there. We also were engaging in a promotora incentive program to help recruit participants for our study before the pandemic, but when the pandemic hit, we had to switch to an online format for providing additional training and education. So at each education session we conducted, we provided refresher training on recruitment for the clinical trial, as well as Spanish language COVID-19 prevention information they could use with their communities. Then the participants themselves encountered barriers to participating, as now during the pandemic, they were experiencing a lot of negative social determinants of health, So their children were being homeschooled, parents were being laid off from work. They had a lot more financial burden, greater stress on moms as they were isolated from their loved ones due to potential for infection and had relied on less support during that time. So also they had no downtime to recover from treatment side effects because they were dealing with children and homeschooling and a whole bunch of, and maybe even working from home. So all we could do in terms of adjustments is to increase our flexibility of our staff and to make sure we rescheduled sessions if they needed to, whenever they needed to. We also developed several protocols and added additional new resources to our cancer resource directory. The participant also during the sessions for the assessment or the education sessions would often share COVID-19 concerns. Remember, these moms were really isolated. And so we were a contact to the world of information for them, and they would ask us questions during our sessions. So we would politely ask, we would say, yes, we're gonna address that for you at the end of the session. Go on with the education or the assessment session, and then revisit her question at the end, making sure we were directing her to COVID related resources in their preferred language. So you can see we ran into quite a bunch of obstacles in trying to continue this clinical trial, but we were very motivated to continue engaging in this trial because we need to provide the support for Hispanic mothers and their children in managing cancer-related distress, especially in these unprecedented times. We were also very aware of the various cancer disparities that Hispanics experience. As they are the largest racial ethnic minority group, they continue to be an underserved population in need of culturally relevant cancer education and services, and they continue to be significantly underrepresented in clinical trials. So that was our motivation for continuing with our clinical trial. We are still working on it, and we'll be ending it soon. But if you want more information on our clinical trial, please feel free to contact me. And I look forward to answering any questions you might have.
Okay, thank you, Dr. Palacios.
You're welcome.
Second, we're going to hear from Dr. Lorna McNeill. She's a professor and chair of the Department of Health Disparities Research at the University of Texas MD Anderson Cancer Center. Dr. McNeill's research focuses on the elimination of cancer-related health disparities in minority populations. Her research has particular emphasis on understanding the influence of social contextual determinants of cancer in minorities, with a special focus on the role of physical activity as a key preventive behavior and obesity as a major cancer determinant. Her research takes place in minority and underserved communities, such as public housing developments, Black churches, community-based clinics, and low-income neighborhoods, communities with excess cancer death rates. She's been continuously funded, receiving grants from various funding agencies like the National Institutes of Health, Robert Wood Johnson Foundation, et cetera, to better understand and design innovative solutions to address health inequities in racial, ethnic, minority communities. Now we'll hand it over to you, Dr. McNeill.
Okay, great. Thank you so much, Amy, for the GMaP invitation. And I really enjoyed Dr. Palacios' talk as well. As a trial that was ongoing, you had to figure out what to do. And I'm sure there are lots of us that had to figure that out. Mine that I'm going to talk about today was slightly different because it was a study that was just getting ready to start. And so I made some different decisions, and we'll see whether or not these things pan out. But I wanted to first start about, I guess, what COVID looked like for my institution at the beginning of the pandemic. So you can see over here, this is March 9th, when at least at MD Anderson, we started to close the campus to any visitors, escalating to about March 13th, where basically everybody was sent home. And then also all of the research was suspended at MD Anderson during March of 2020. And all in-person clinical trials, everything ceased. So probably for the whole end of March, all of April, there was no research activity happening. And then, of course, our lab-based folks were like, we have to be in our labs. We have ongoing experiments. We can't lose years and decades of work. We've got to figure out how to get back in the lab. So COVID-19 Research Task Force was launched in April to try to figure out how to open lab-based research. So they probably talked about that for April, all of April. And by May 1st, they had quickly figured out how to separate their labs from patient contact, because I think that was our major concern working in a hospital setting was cancer patients that are highly immunocompromised. We cannot have any of us just walking around exposing patients to COVID. And so we called it the moat, to literally how to keep all of what we're doing separate from what's going on with patients and interaction. And so probably around May 11th here, you see reopen lab and clinical trials. So it wasn't down for maybe even 2 months, but not so for community-based research or behavioral science research. Even though that got opened back in May of 2020, it wasn't until maybe September that there were some aspects of behavioral research that were allowed to get back open, partly because I think there was just a sense that it wasn't the same urgency there was with the lab-based and the clinical trials, particularly therapeutic trials, obviously, that are life-saving. So we couldn't make that argument that our work was maybe on the same level of saving patients' lives. And some of our work, and particularly my research, is all community facing. And so then there was the issue of whether or not you could allow community members to come back into the cancer center, and would that increase the risk of transmission? And they were concerned about, and most of my research is physically in the community. So then the question was, well, if we allow our staff to go back in the community, are we putting y'all at risk for, contracting COVID? And so while they allowed behavioral science phase 1 reopening, that reopening was to allow behavioral interventions for patients only. So it really wasn't necessarily the kind of research that I do, but it did allow some of the behavioral science population-based research to continue. But as you can see, all through December of 2020, no, there was no community-based research that was going on. I'll fast forward a little bit to say that from December 2020 to October 2021, which is when community-based research opened, a lot was going on during that year. I was almost partly resigned to just community-based research being closed. COVID was just starting to get worse and worse and worse, right? Like, more and more infections, it was more and more deaths. It just didn't seem like the kind of research that we do. I was trying to launch a physical activity study. It just didn't seem to be on par with where the country was going, where their mindset was at about kind of doing that kind of research. Then there was a little light at the end of the tunnel with the vaccine, but then vaccine hesitancy came upon us. And so the vaccine was here, hooray, but then people wouldn't take the vaccine. And so from a cancer center perspective, we're very concerned about contraction in the community. I live in the state of Texas, and in low open state, you could do whatever you want to do. You're free to get COVID or not get COVID, it's up to you. But because of those policies, our COVID rates were, very high, comparable to Florida and other states in the South that had really, sort of high rates. So you can make an argument in the state of Texas, one could argue, that it kind of wasn't safe to do research. And so I'm fighting for it internally with our leaders to make an argument for how this is mission critical for us to still do community-based research. Because mind you, it wasn't just community-based research, it was any activities in the community. So our presence in the community was also eliminated. We weren't able to go to community meetings once community meetings, came back open. We weren't allowed to do our normal course of work for fear of increasing our risk for getting COVID. So for a whole year, it was a really challenging time for all of us. And I'll talk about sort of some of the pivots that we made. But the moral is community-based research, the ending is community-based research opened back up in October 2021. But then it closed back down again in December of 2020 because of, what was the variant at that time? Was the, how could I forget? Anyway, I was Omarion. It's not the singer, but the COVID variant came in. Everybody almost got COVID in December, right? And then it was closed again. And it recently did not open until 2 months ago, back in February 2022. So as of February, I am now allowed to really fully kind of begin my community-based research. So what I've been doing all this time. So I'll mention in terms of just a little bit from a community engagement perspective. So that was one aspect of what we were most concerned about. And I'll talk to you here about a little bit, one program that we were doing then and are still doing now at MD Anderson in terms of a slight pivot. So obviously for all of us, COVID allowed us to think outside the box in terms of how we would remain connected to the community. Of course, at that time, the chief interest from community members was COVID-19, and even though we're a cancer center, was seen as a trusted source for just delivering and disseminating COVID-19 information. So we took some of our community meetings that we normally would have in person and actually created these new community huddles where some of our partners, several of our partners, and actually new partners, people we hadn't reached before, came to these monthly huddles. There was a general one, and there was also one that was focused on the Hispanic community specifically. But in this community, partners were sharing new collaborations, talking about research, because one of the things that happened is an increase in grant applications. So I'll talk about that a little bit. But it was one of the ways in which we were able to continue to engage with community. Interestingly, I get asked this question all the time, hey, there's this great aspect of COVID where people are now engaging virtually. What parts of that is going to stay, you think, post-pandemic? And at least in some community groups with some partners, this has actually been good. This has been a way for people to engage, to not have to think about childcare, to not have to think about travel time, to not have to be able to be engaged, even if for 30 minutes, and be able to leave. And so for some aspects of our community, we've seen increased participation, actually. And then for others, though, this has been a challenge and not their preferred form of engagement. And other kinds of community approaches I can talk about, sort of, I think, in Q&A. In terms of my research, I had a major study, two major studies actually I was going to launch, but I'll talk about this one called Project Faith. I do community-based research and primarily do work with African-American churches. So right around this time, I was getting ready to launch a 3-arm cluster randomized controlled trial of 18 African-American churches and recruiting 816 families. It's going to be one parent and one child, ages 10 to 16 years old, to increase physical activity, and it was really our weight maintenance intervention. We had developed partnership with Houston area churches, had recruited and enrolled our first 6 churches in the program. And part of this intervention was going to be recruiting members of the church to serve as health buddies. So we did our health buddy training from 2 of our churches. So the churches are trained, everybody is raring to go. We've begun recruitment advertisements, and we got initial signups, and then literally COVID happened. All of that was shut down, wasn't able to really move forward. So of course, this is the program elements. There were peer support groups that were going to be in person, led by the health buddy and co-facilitated by one of the staff members. There were health buddy sessions, which were like one-on-one, where a family would meet with their buddy one-on-one. The other one was group-based support. And they were going to get coaching calls and counseling. So at the time, the decisions for me to make was, do I pivot and go virtual or not? Well, that was a really hard decision for me to make, because the going virtual meant I was not going to be able to do any in-person assessments or collect any data, right? So it was really kind of redo of the study design. I was going to not be able to collect objective measures of height and weight, not really be able to collect objective measures of physical activity. And everything was just going to have to be self-reported. And we know which is highly unreliable. So am I going to do a major study using self-reported data is what I was, what was against me. And that was a really hard decision, to make. Could I make these program components virtual? Knowing the community that I work with and the engagement I've had with African Americans through churches over many years, it's all in person. Were people going to be receptive to a virtual peer support group, a virtual coaching session? Well, coaching session was a virtual interaction. I didn't have pilot data that told me that that it was feasible and people would like virtual. So now I'm just totally switching it because of COVID when I don't have any data or evidence that says that this is going to be highly effective. That made me uncomfortable. How would I recruit participants? Our main way of recruiting was in person at the church. We would go, sit in the lobby, recruit people. We've done this for years. It works. Would virtual recruitment work? How did that work? Like, how would we advertise what we do? How to maintain engagement and competing demands. It was about COVID at this point. Were people sufficiently interested in getting involved in a physical activity, 18-month physical activity intervention? People were losing jobs. People were getting COVID. And then really at the end of the day, I was just questioning, is this virtual intervention going to be effective? So the answer to all of this at the end of the day is I decided to not move forward with the study. I decided to keep it paused, not transition it to virtual. And now that it's back open in February, we're going to start the study. So there's significant costs involved to that, personnel costs. How am I going to fund everybody, keeping everybody having a job, you know what I mean, if we didn't actually fulfill the grant aims? So this is one of the ways I feel like we've leveraged, you know, COVID-19. So like many of you at your institutions, though, there's been all these new focus on issues around disparities, health equity, diversity, equity, and inclusion. I'm sure that you've not missed that increased focus. One of the actions that my institution took, which was really grateful, is they gave us bridge funding for our community-based research to fund us during this time where they basically shut us down. So that was where I got some of the funding, was to continue to hire staff, and they continue to work on things, don't get me wrong, but just not this particular intervention. As well as all of you may have seen flexibility from funders, where there was just more flexibility. Say, oh, you can't do this. Oh, you need to pivot here. It's cool. It's fine. We're okay with it. So it was in the spirit of being able to be flexible. And in my case, the decision to not move forward was equally accepted, you know, as well. In my institution, it was new, committed in funding. Around a $200 million endowment was created, focusing on underserved. And again, COVID and social justice, right? The murder of George Floyd, all of this attention around inequalities is prompting all this new attention. My institution, a new chief diversity, equity, and officer position was created. We established a new executive committee, the diversity, equity, inclusion, that reports to the president, a new CCSG focus for those that are involved in cancer centers specifically. There was going to be a new emphasis on diversity, equity, inclusion. And then this last one is where I probably spent most of my time. New grant applications on DEI or health equity from other faculty at the Cancer Center, right? So I have probably been a co-investigator on a proposed 45 applications over the past 2 years, of where people have just been coming to me. They need a disparities expert. And they're like, who can we partner with? It doesn't matter what the topic was, but I'm an expert in that area. And so I have been inundated with faculty who now have an interest in this area. I'm sure a lot of this is helicopter sort of disparities people, but to the extent that some of this might actually be a new area of research, I was happy to support that. But then of course, all the funding mechanisms that have populated up. And I've just named the pharmaceutical companies, like completely engaged in this at this moment. NIH is focused on it, including sexual and gender and minority health. And we can go on to as many disparate populations as we can name. There's a new RFA that is out there. And the ability for us to collaborate and extend our area of research. So I've spent my time in collaborations, over these past couple of months. So I'll conclude a little bit to talk about challenges and motivators. I think this has been challenging for postdoctoral fellows, at least for mine. It was challenging for all of us to figure out how not to see each other and how you learn. It was almost a questioning, how does one learn? And challenging the idea that you learn via in-person sort of instruction, when in fact, it's conversations. It is hands-on learning. You're not in the field. And so a lot of what we do in my work is engaging with community members. And there's something about the physical interaction. but we've pivoted to learn how to learn virtually and try to make, sort of make up for that gap. I think it's definitely affected team science. It's affected my team and the way we interact with one another. But again, we've still been able to be highly productive, and many have examples of where they've been more productive than they've ever been in their entire lives. And I granted, everybody thinks and moves and works differently. And so this has spurred lots of creativity, innovation for others, and for others, it hasn't actually. And I do think it's impacted knowledge sharing. We're sharing a lot in one way, but then, not in other ways. And I, have some thoughts about that. And then of course, the challenges with community engagement. In my particular case, I work with faith-based communities. African-American churches were completely shut down. And even as other churches, non-Black churches started to get up, they were late to the game in terms of getting back up and in terms of in-person worship. And so that's also been a challenge for me. But motivators that kept me, and I think our whole team, and really all of us that do this work motivated, is the communities that we serve, wanting to get back to community research, wanting to get back this type of interaction is really important. There's a strong culture of collaboration, I think, for those of us that do disparities and health equity research. And so every time someone came to me with a new idea about some new area of disparities they wanted to move in, I was definitely encouraged. And then, like I said, overall, a general return to normal. Still trying to figure out what that means, because my institution is moving into a place where they kind of want us all to work from home for the rest of our lives, kind of, right? They're kind of like, you don't ever really have to come back. And it almost, for those of us that want to come back like me, it's almost slightly frowned upon, right? So there's going to be a new, we're calling it the future of modern workforce or something like that, where space is going to be downsized and the way that we interact and collaborate is going to change. And so I'm still figuring that out, but still excited to figure out what that's going to look like. So I will stop there. Thanks for your time.
Right. Thank you, Dr. McNeill. Next we will hear from Dr. Kelly Glazer-Barron. She's a tenured associate professor in the Division of Public Health, Department of Family and Preventive Medicine at the University of Utah. She's a clinical psychologist with over 15 years of experience in behavioral sleep medicine. Dr. Barron's research studies the biological, social, and behavioral mechanisms linking sleep and circadian disturbance with cardiometabolic disorder and developing sleep interventions to improve health. Dr. Barron's research is supported by multiple NIH grants and has been widely covered by the popular press, including the New York Times, Consumer World Reports, Cooking Lights, and WebMD.com. And I will hand it over to you, Dr. Barron.
Thank you so much. I really enjoyed hearing my colleagues' presentations. And, I think there's the universality of just how challenging this has been to conduct research. I'm going to talk a little bit about my own experience in my studies, which are a little bit different because I'm doing a little bit more in-lab or mechanistic research. But I also want to spend some time talking about maintaining productivity on the writing side of things and recognizing burnout in that aspect. So I think we're all hitting on some different challenges and points that we've experienced. Let's see. I turned on the annotate tool because I was playing with that, but now it's not letting me advance. So, oh, there it goes. So I'm going to talk about just the challenges of continuing research. I gave this talk like this 2 years ago, and it was interesting and kind of reflective in my own work to think about what's changed and what's remained the same in 2022. I'll talk about my own protocols and what was going on in our lab here, and talk about managing staff and students during this time, and then adapting my own productivity and your own productivity during these times. So, this is the picture I put up in 2020, and I still feel kind of like this pug. And these were some things I said in 2020, and they're still true. Like, this is not running subjects, it's more like walking. I just feel like everything is slowed down, and everything takes twice as much work for half as much productivity. It's not in your head. This is really hard. Everything, it feels like, I always feel like getting research going is like getting like a wagon, pulling a wagon. It's like once it gets going, it's a little easier, but like those first couple of steps are really hard. And those of you, so I'm not from Utah, but there's a lot of like pioneer handcart mythology that people, not mythology, but like history they talk about. So that we feel like we're pulling the Mormon pioneer carts. So, so if you want to open up your annotate tool on your own screen, those who are here, I just want to be a little bit interactive, but this was a grid that I put up in 2020. And I'm curious, which of these are still true for you? What are your challenges related to the pandemic or in general right now? For example, the stopping and starting of recruitment. I'm curious how many people are running subjects versus working with collected data. You know, unable to safely complete your study due to close contact or that sort of thing. You know, in thinking about this, like, for example, like the no childcare thing. Oh, thanks for annotating, everybody. You know, a lot of people with young children were really struggling. I know I had 2 10-year-olds. I had 3rd graders, and then they went into 4th grade and were doing school from home. And so we all kind of took separate corners of the house. And it was constantly, there was a spider always in the room whenever I had a conference call. It is hard to get to coordinate schedules. I feel like the no time to write is really an issue for me, in that the Zoom meetings are just like oppressive. It's gotten really out of control. Does anybody want to share how any of these categories are affecting you? Or any of them that I don't have up here? You can put it in the chat if you want. I know one really big area for me is that I was ready, and I think that Lorna was talking about this as well, that we were essentially open to run research, but my department being public health, most people being in epidemiology, they were really stringent on they were really told people not to come into the office. And the problem with that is we're doing in-person data collection. And so, you know, I felt like the interaction with my division head on this was really problematic. And the second shutdown, or this, you know, the second wave, he was more supportive. You know, I came to him and I said, you know, we need to come together and figure out how to do this safely, because research is open, and in the end, NIH is going to expect some results. So, you know, we're on the same team, but I need your support. You can't tell my employees they can't come in, you know, things like that, because we have in-person research. Things like that. Anything else? Okay, well, you can see many of these challenges, I mean, they're not only pandemic related, but many of these challenges are still happening. They're still occurring. And so I want to talk briefly. Let's see if I can clear. I can clear your check marks. I wonder. Let's see, is there, oh, clear. Clear all drawings. Okay, good. So I can use the annotation and I can remove it. Zoom achievement unlocked. Okay, so in the pandemic, I was 3 years into one of my R01s, and then as the pandemic started, I was funded for 2 new studies. And as my colleagues today have pointed out, it's very different to have the pandemic hit while you're collecting data versus when you're setting up, because you can make more choices when you're setting up. And even though we were starting year 3 of this R01 laboratory and naturalistic study, it would still be a big sacrifice to change the protocol too drastically. You know, you would basically be losing some data. And so this study involves 5 visits over 1 year, and it's looking at how sleep and circadian disruption relate to appetite regulation and neuropsychological processes. And so it involves doing some screening both in the lab and at home with some questionnaires and wearing some wrist-worn sleep monitors. And then they come back in the lab and do some neurobehavioral testing on a computer, and then dim light melatonin onset, which is measured by these multiple saliva samples taken up into their bedtime. We also have them come in and do some glucose testing at the lab, and then do some neurobehavioral testing in the evening. So they have 2 full days of the lab, followed by a 6-month follow-up where we do a quick weight, height, glucose screen, and then a 12-month, we're doing the melatonin testing again. And so this is a lot of time together in the lab. It takes a lot of people in the lab in close contact to run it. And so it really posed a challenge for COVID because, you know, number one, who was signing up to come in to do a 5-visit study in COVID, you know, among healthy people, for example, this is mechanistic. They get compensated for their time and they get to help science, but they don't get a whole lot out of it. And then the other thing is, you know, the risk to the staff about being together with a participant and being in close contact. You know, when we were early on, when we were talking about, you know, the 15-minute exposure and that sort of thing, this was definitely more than 15 minutes. And so the timeline of this, similar to other folks who talked about this, is that, you know, recruitment ground to a halt March 2020. And we saw it coming, and I made sure that everybody had a laptop at home, was able to access their files. We also early in March, end of February, we were slowing down recruitment. We just said we're going to focus on people who are already enrolled and keeping them in, and let's see what happens with this. Well, now we know, but that is what we ended up doing. And we had quite a few people scheduled to do the laboratory visits that ended up dropping out of the study, you know, in that shutdown time. And some of them we weren't able to reschedule for later. So the university opened back in June 2020 for in-person research. But we were still dealing with some pretty substantial challenges, you know, obviously in the community, and that people were not signing up to do our study, but also employees didn't feel comfortable coming in to do the study. It was a really stressful situation. And if I had it to do over again, I had one employee in particular who had an elderly relative who was going through cancer treatment. And I think it would have been better to have the open conversation that he didn't feel comfortable coming in. He wanted to stay employed, but, you know, perhaps we could have reassigned him in the department or something. You know, it ended up going really poorly. And I looked at my role as, you know, listening, trying to plan ahead to have a strong protocol to try to keep everyone safe while things were open. But in order to do our study, it had an in-person component. Like, there really wasn't anything they could do. Another thing is that I was home taking care of kids who were doing their online school. And so if I could have physically been here as more, that would have been a stronger leadership role. And I should have advocated for that. I think the main issue was that I didn't feel comfortable coming in when we were told, don't come in unless you are directly doing the job. And then also dealing with the craziness of online school. So other things that we did, we tried to make it as safe as possible, and then we adapted what we could. And that means that visits 4 and 5 that we're just doing the quick follow-up, if we could mail somebody their watch. They could do the questionnaires online, and we could even mail them the A1C Now kit to do their metabolic variables, you know, if possible. So the things that we could do at home, or we just did it in the parking lot. You know, we got as flexible as we could. Other studies that I'm working with were able to adapt their whole protocol to be through mail or at home, but this one we were not. So we adapted the pieces that we could, and that improved subject retention. And then on top of that, as we got rolling again, we've had these like periodic slowdowns. And so we've had to just kind of plan ahead to when we had to pull back on recruitment, and then when we could go full force. And I think the biggest issue there too was with Omicron especially, was we didn't have the staff to run. And so we'd have to double or triple schedule shifts, knowing that people would be exposed or sick, and then participants were rescheduling. So we decreased our goals for recruitment, knowing that we couldn't handle the capacity based on everyone rescheduling and that sort of thing. And so I already talked about this, but, you know, preserve the primary endpoints and move what can be remote to remote, focus on the safety protocol among our staff. You know, the university has one and they have contact tracing, but what's our internal plans and for keeping everyone safe? And then now we're really thinking in this whole year, thinking about what would it take to catch up? So what would it take to reach our prior levels and expected levels of recruitment, what would it take in addition in terms of resources, time, money to catch up to our expected number of subjects? I don't think that's really possible at this point. What sort of money would it take to run an extra 6 months or a year of the study with a no cost extension? And then what is our anticipated effect size if we reduced our N? So that's just talking about our more intensive protocol that we couldn't be, that we really couldn't move it to remote. I also want to talk about just like managing staff and students. And, you know, in terms of returning to the workplace, like Lorna, I'm a good office worker. So I would prefer to come in and do my work and then leave work and do a little bit more work in the evening, but like kind of leave work at work. My employees, they prefer to work from home, and that's what they tell me. And I know the mental health struggles of the pandemic are really salient, and I want to do what I can to keep my employees who are good workers, who know my protocol, who are well trained. You know, employees don't grow on trees, so I want to keep them happy. Like really, I want to be flexible for them, but I find it really challenging. I miss a lot of things of the face-to-face interaction that we have as a team, and then also I can make sure to be here personally when they're here doing their in-person work, but I also understand that they feel more productive doing some things from home, and it gives them more balance in their life. And so some challenges that I've experienced is, first of all, navigating department policies. Our department really doesn't have a strong policy at this point. And in fact, it's just really job dependent and dependent on the manager. So while I'd like to say everyone should work from the office this many days a week or that sort of thing, it's really out of line with what the rest of the division and department are doing. And I think that would stand out with a sore thumb. So I've really said the expectations in the office are related to the study that you're running. And I've tried to be really transparent and also not feel like some people have special treatment or that sort of thing. And so to really navigate it case by case and study by study. And then to really focus on the expectations for productivity versus expectations for work hours. And I, for example, have one employee who has a small daughter, and it wasn't so long ago that I was in those shoes, and she does a burst of work at 6 a.m. She's here usually pretty early. Sometimes she's here by 7 and then she leaves by 3. And sometimes she does a few things in the evening, but she's not working like the straight 9 to 5 sort of thing. And she does a lot of work. She does a great job. And so I want to support her. And I think that's totally fine. I did have one employee in the pandemic who his work hours went totally crazy. He would start work at like 11 or 12. And then he would do stuff at like 3 a.m. And the problem was he was missing the core work hours that other people were working. That was bad for communication. His productivity was down. I felt like he just was stressed and kind of a mess personally. And so that was not good. I had to kind of enact and shape the hours, like log on by this time. This is when we expect you. So I think having some flexibility is good, but it can't be limitless. I think people lose motivation. There's been, a lot of stress going on in people's personal lives during this time. Experimenting with some things like, for example, Thursdays, we have our lab meeting and everybody's come in if you don't have other classes or that sort of thing. And then managing undergrad volunteers has been really a challenge during this time. I don't know how many of you work with undergrads, but it used to be that they would sign up for 6 hours a week or so, and they would come in and check in for these 6 hours in person. And now when they do it from home, it's like their whole schedules have gone just totally haywire. And so they say they want to do hours, but they never do. So we have to work really hard for them to like schedule those hours and more feedback. We've tried things like Clockify to log their hours, or right now we're kind of doing like a weekly check-in with one of the research managers so they can track their hours. But it's been hard for them, and it's been hard to make them feel like part of the lab too, and get the other parts of working in the group. We've also tried to do things like thinking about the bigger concept of building trust and collaboration among team members, and trying to balance the check-ins versus tons and tons of meetings. So just having informal check-ins over Teams versus having tons of meetings. So I was doing a weekly lab meeting, but it just felt like too much to have operations meetings for every study and then a weekly lab meeting as well. I did send everybody adulting stickers very early on in the pandemic, or try to think of ways to celebrate meeting a recruitment goal or getting a study launch or that sort of thing. So I thought these were really cute. They were things like, I ate a salad or things like that I thought were cute. Or sent people like notepads. Normally I would bring in snacks or that sort of thing. And if we're not in person, I was trying to think of other ways to make people feel like part of a team, or to feel, other than saying, being gracious and appreciate what they're doing, to just have ways of showing your appreciation for the work that people are doing, and try to bring in some positivity. Our group has also wanted to get together and take a hike or something like that. And so we're going to try to do some of those things this spring, now that it's a little bit safer. And so at this point in the pandemic in 2020, I would actually recommend, in thinking about your productivity, to just think about the bigger picture, and hopefully you have this in your individual mentorship plan, but to think about, what are your achievements in the last 2 years? And also, what are the things that you've been putting on hold that you need to move forward? And this is what I'm thinking about right now at 2022. Now, it's 2 years into this. So, I'm super pleased that I've kept things going. I've submitted grants. I've completed a couple big projects. I'm getting back to conferences. I'm making a commitment to exercise with my friend every week. But what are the things I put on hold these last 2 weeks, especially if you're in a 2 years, if you're in a postdoc position, you don't have the time to do that. So, for example, I think about, I've lacked the energy for the program building that I'd like to. I mean, I couldn't even fathom starting another Zoom meeting. Yeah, I still can't, but there's an energy here and interest in sleep and circadian rhythms. So I'd like to somehow build some cross-campus collaboration. So how can I do that now in 2022? I've held off on starting new pilot research. It was hard enough to do my existing studies. And I say these pilot studies and new collaborations, I've only been at University of Utah for 4 years. And so half of my time here has been in the pandemic. So I got to this new institution, I started some new collaborations, and then some of them have fizzled because I don't see new people. So I need to do more of that. Obviously need to do writing, and also I'm not eating as healthy as I'd like to. So then I want you to think about also addressing your challenges of productivity. I really like this cartoon. You probably have seen this as well, but all of us just feel exhausted from pivoting. I'm just tired of pivoting, but unfortunately we still have to roll with the punches. So the last thing I just want to do is to share some of the techniques I have for dealing with burnout, because burnout is real. Everyone's probably feeling it. I know I'm feeling it. I was supposed to have my first vacation in over 2 years, and then my husband broke his leg and had 3 surgeries, and then it got canceled, which is so sad. So I still am waiting for that vacation. But when I feel burned out, these are the things that I do, is that I recognize it. I get outside. I schedule some social activities. I'd also recommend that you look to finish something like a quick win. Review your checklists and schedule and make a plan to complete a few things. Do some reading, reconnect with your curiosity in the research area, brainstorm with collaborators, find an accountability buddy, and then skip some meetings if you need to. We all have far too many. So in summary, the last time I gave this talk, I said this time will not define you, 2020, but actually now at this point, your persistence will define you. So you're going to have, in order to make progress in this area, everybody is struggling with pandemic related slowdowns in their research, but you have to have protocols and contingency, make progress on the controllable, and seize the moment between waves, and just know that you're not alone, that this is a hard time to be productive. It takes twice as much work. So thank you very much.
Thank you, Dr. Barron. Well, we have heard a whole lot of wisdom and good ideas and just really interesting things that these three were able to do during the pandemic with their research. We're going to open it up now for Q&A. If anyone has questions, you should be able to unmute yourself, or you can drop questions in the chat.
I'll start out by just saying thank you all for sharing all of your research wisdom. As a qualitative investigator, I resonated with everything all of you said, actually, and just was thinking about the challenges of working with a research team that I think all of you probably had at the same time, and your choices that you made. I found the experience of, I was coming into the office, even though, because I was alone in a wing, there was no one else here. So it was just me and a bunch of closed doors through the entire pandemic. But I have children, so I couldn't really get anything done at home. And my partner was able to take care of our kids. She was working at home during the day, but it was really isolating. And I found that working with the team, while it had a lot of opportunities when we transitioned to kind of virtual team space, it was also challenging. I think what Kelly was sharing about trying to have accountability and getting people engaged really resonated with the challenges we were having also. Like, how do you know when people are there? How do you know what they're doing and who they're talking to? So I'm just curious, where you're at now. I know Dr. McNeill also talked about the fact that MD Anderson, I have another partner that I work with there on another project, that you might be in a persistent virtual space. So how is that? What are your plans for working in this kind of continued hybrid situation?
Yeah, and interestingly, my husband works in a national news company, and he's been remote for like 15 years. Wow. And so I think it's, I've really, and he's a good manager, so I've gotten some mentorship from my partner, but who's done this a long time. And it's very different, because initially in the pandemic, it was panic. We were just, we were shut down and everyone was scrambling. But now if this is going to be our situation, people need to behave like professionals. And so there is a log on time, there's expectation. It doesn't mean someone can't throw their laundry in or like whatever, but they say when they go, they say when they're away from the keyboard. So I think like teaching us about how to have the culture of accountability, but it's also much better to do this with somebody who's a professional versus somebody who's like a first year right out of college,
right?
Research assistant. Like they need a lot more supervision, and I find it's very hard to supervise somebody remote for that. I'm still like, what the heck? Like they're kind of going rogue. They're doing things I didn't ask them to do and not doing the things I wanted them to do. So it's a managerial struggle, and we're not going to go back to the way things were, and it wasn't good for people either. That was, things were not good for people either. So, so let's try to make this work for people, especially when it's hard to hire. Right now, I really want to prioritize my employees' wellness and feeling like they're listened to, and that if they're productive, I want to trust them.
Yep, I really agree with that.
Yeah, I'm happy to say that, productivity has not really been an issue. And I don't know why necessarily, but I feel like, and maybe it's, remember when COVID first began, people were losing their jobs left and right. And so I don't know if people were afraid of that. So people were willing to show how much they're working. So there were no missed deadlines, and people weren't, you weren't wondering like, what are they really doing, sort of with their time. I think there's still issues of fit. When you bring somebody in, you still might feel they don't have the skill set that they need to do this particular job. But interestingly, like many of us, I hired several people during COVID, most of which I never even met. So one woman I've been working with for 2 years, I have never seen her in person. Once things started to kind of go down, our holiday party, which we were supposed to have in December in person, we didn't. We had it in March. I saw her for the first time. And it's so funny because she's super tall, right? But I didn't know that. And I'm only 5'2". So it was just really, really funny to just, sort of meet people that you've been seeing on Zoom every single day, right? Or, weekly, but you've actually never met in person. Now, how we transition back to the office, I'm concerned. It's really my concern. If I really think about it, I'm old school. It's the way that I want things to be, the way that I enjoy interaction. And it is like Kelly, what it was before, you know, like we show up for in-person, you know, meetings and, you know, so forth. And my teams are all younger, right? They've all pivoted and adapted very, very quickly. I think maybe, I don't know if Rebecca said this, somebody else did, but that they prefer this, right? In a way that I definitely don't, you know, prefer it. So what I'm going to start to institute is that basically people come in 2 days a week, work from home 3 days a week, and even the 2 days, and it doesn't have to be all day. I just think there are a couple of meetings where we can still sort of see each other, interact, but most of their life, I think, is going to be the way that they want it to be. And quite frankly, I don't actually think I have a mandate. Like, I don't think I can make them come to work, to be honest, right? Because my institution has basically said that if you can do your job 100% remote, they want you to do that. And that you almost have to make a case for why you need to be on campus. So right. Even if I don't like it, I feel like moving us out of office space and into a homework environment is what the future is going to look like.
And that's what our issue was. I had somebody who struggling emotionally during the pandemic, but also they had in-person work. They had to, equipment came in the mail, you know, they sent it to participants, it came back, they had to download it. They didn't have a good work environment at home, you know, entry-level employees, it was distracting and didn't want to use their personal cell phone. I didn't have a budget for research phones for everybody. We were trying to set up we set up a Google Voice, but you know, like they didn't want to use their cell phone minutes. And it was like, stuff was piling up here. So I said, you need to come in 3 days a week. And that's when my division head said, oh, you can't do that. It's the pandemic. And you know, so there's a little bit of back and forth, but when Delta hit, we had a much more productive dialogue about that. So nobody was surprised and he had a better sense of what my studies needed. Yeah. And that person eventually quit because it was not a good fit it wasn't a good fit for them. We've survived.
Yeah.
So on my end, so we did have a program manager who's Glazer, she's in the audience, and she's been fantastic in terms of helping to coordinate and keeping track of who's doing what. And most of our staff is students, graduate students. And so they had to report in with her. And she watched their progress and their productivity. When our funding ended under the U54, I lost the ability to support her full time. So I only had her a very tiny proportion of her time was dedicated to our clinical trial for several months. And it all fell on me. And it's just too difficult to do everything else that we're doing, trying to maintain and run the clinical trial, and then also making sure that the students are doing what she's supposed to be doing. And then, so we obtained additional funding through our university, and we're able to hire back almost at full time. And so she's back in assisting me in tracking students. But working online and maintaining work on this project, I think helped to ground some of our students during the pandemic, because they had something to do, right? They were committed to something and not constantly thinking about the pandemic and such, and the distress of it. It also helped a lot of our students who were coming in from out of town and had no connections with each other and had never met. And now we're living alone in an apartment. Our meetings gave them that connection they needed during the pandemic, which was really, really beneficial. So there were a lot of pros and cons in terms of the way we're working right now. How do we move forward from this point? Our trial will end June, and most of our staff is graduating and leaving. So I'll be like working with brand new students and training new folks. And I got to make those decisions. How are we going to be working on the next phases of this research? And so I do have some decisions to make. I hated working from home initially. I hated it. But I do have a 1 hour commute to the office back and forth. And so now I'm loving it. Now that I know what it's like to work from home and found my group here. So it is going to be a struggle to go back to the office and engage in that way. But I do miss interacting directly with my students. And I think they miss that too. There's a different quality of learning sometimes, I think, when you're working directly with each other.
I've started to have a quarterly or maybe every semester meeting with my undergrads about like how to be a good RA, because I noticed at the pandemic, the first time it happened, that I got all these requests for letters and I didn't know any of them, and I didn't have enough to write a letter on, and I barely knew them. And so, you know, very early on, I kind of talk about like what we expect from you, you know, how we can get to know you, what are the experiences, what are the things you can do that is going to get us to know you, you know, and that sort of thing. And try to think about opportunities to get to know them and to get a good research experience. Those are things like volunteer to present in our journal club, or, you know, things like feel free to stop by when I'm in the office and you see me here and say hello, or, you know, just different ways that they can volunteer on certain projects. And it comes naturally for some students, but I don't expect that they know that. I don't think it comes naturally for everyone. It didn't for me, I'm sure.
That was a great question. Thank you, Dr. Kano. And thank you all for sharing what you did with your teams. That can be so challenging, even in times where we are all physically together. Did anyone else in the audience have questions they wanted to bring to the panel? If not, I thought of one. Oh, yes, go ahead. I see you.
Hi, I have a quick question. Thank you all so much for your presentations. I really learned a lot. So I'm 7 or 8 months into my assistant professorship position. So I decided to make the pivot from a postdoc to faculty position during the pandemic, because yeah, not all of us can afford to be postdocs forever. So
Congrats.
Thank you. Needed to make the jump. So one of the questions that I had, because I have undergraduate students that are really eager to join, working with you in the lab, et cetera. But I'm just noticing some challenges with coming from 2 years being virtual to now my institution is in person, and they're taking away a lot of the COVID requirements that you have to have. So I'm just wondering, in terms of, for those that are working with students, what are some of kind of like the orientation processes or the meetings that you had prior to students joining your lab? Did you have a formal orientation? Was it virtual? Was it in person? What are some of the agenda items that you covered, et cetera? So any specific or practical applications that I can adopt would be really helpful.
I'd be happy to go first, because I brought it up, but we have a lab manual, number one, that outlines all of the onboarding processes, like the city training and HIPAA, and downloading Teams on their phone. I'm challenged because undergraduates these days do not use email, and they expect us to text them, which I'm not going to do. And so we're working on, we were using Asana, but now we're going to use Microsoft. We're using Microsoft Teams. So just establishing the communication, the frequency of communication. And then also we have a policy of, a certain amount of time, if we don't hear from them, they kind of just disappear from time to time. So if we don't hear from them in 1 week, then we send them if they don't show up, but they don't do their phone calls for recruitment, they don't come in to do letters, then we reach out to them. And if it's been 2 weeks, then there's a potential we're going to dismiss them from the volunteer experience in the lab. And so we need to be a little bit tougher on that. But, after 2 weeks, then I send them an email. Is everything okay? Do we need to change your hours or reassign you to another task or that sort of thing? And so we assign each student to one of the 3 projects that we have running. And then that project manager is the one who directly manages them. We encourage them all to sign up for either independent study or the university research opportunity program, or there's this LEAP program. There's a couple of different programs. We hope that they sign up for one of those, because then they have a little bit more emphasis on completing something, because they're getting more out of it. So we just talk about, I think we try to upfront establish what we expect from them and what they'll get from us, which are, hands-on experience, learning about research. If they stay around for the second year, then they can be part of an abstract or a publication perhaps, or even do a senior thesis. So we talk about that. And then to know that probably, I don't know, it used to be like, if you took on 5, maybe 4 of them would be good, maybe 1 would drop out. But I think it's more like if you start with 5, maybe 2 or 3 work out. So to know that they kind of fizzle out fast, I think that they overestimate their time. And so the main things are to have a meeting at the beginning of the semester, to set timelines for when they're going to get the city training done, and then to have the expectation that they come to at least one of the meetings a week, whether it's an operations meeting, a lab meeting, or they check in with us face-to-face in some way, so we know what they're working on and what we've assigned them to do and that sort of thing. It's still not working great. It's really hard.
All right, thank you.
So more recently, we have not been working a great deal with undergraduate students, but the protocol is the same for graduate and undergraduate students. So when they onboard on our projects, because we're used to they're required to assist with the clinical trial procedures, they do all the human subjects training, they do good clinical practice and HIPAA compliance training through the city format. And then we ask them to provide a schedule of the hours they're going to work. So if we're hiring them for 10 hours, we ask them to split their hours across 3 days, because it doesn't work for us to work entirely 8 hours in one day and then maybe 2 hours here. They have to spread it out at least 3 days. They are all required to participate in meetings. So we have multiple meetings for the clinical trial throughout the week, because we have to keep everybody blinded on different aspects of our clinical trial. And so we do have those. And then we also have full team meetings. And so we see them there, and on the full team meeting, they report out on their progress in front of their peers as well. So, that keeps them also, I don't know if it's keeping them honest, but they know they have to report out, and it's not going to look good if you're not being productive. Of course, we do ask them to report at the end of the day, what did you accomplish today on the tasks that have been assigned to you? And they report every day through email to us, giving us a checklist of what they did that day. And so that's how we manage.
Thank you.
I have a question, if that's okay. So it was kind of brought up that obviously when the pandemic started, that everybody had to kind of pivot or shift their research, and some of that looked like that some people just stopped to study just completely, or other people had to adjust it. But now that it's 2 years into the pandemic, and it seems like there are like the multi-platform, multi-environment type of study is becoming more and more common. I guess, how do you think that's going to affect the quality of studies or like information or outcomes that happen like from the pandemic to now, and also moving forward?
I think that's a good question that we will find out in time. So for my study, I'm going to end up making a hybrid. I don't want to, but I think to your point, that's what people want now, right? So this notion that everything is in person, or this notion that, because the question is posed, why can't I do it virtually, right? And so from a recruitment perspective, I think the ability to offer, sort of intervention in a hybrid format is what I'm probably going to need to do. And I'll have to figure out what that looks like for future studies. Now, but then I'll need to see how effective was this type of format. Now, so I do think that there have been other studies that, I think in the past, I don't know about hybrid, right? You could have a virtual study, and people have done telemedicine type of studies, or colleagues do smoking cessation that were all done telephonically, right? Where you actually have no in-person interaction. That's evidence-based as well. But I think this notion that some people are going to be, sort of in person, some people are going to be hybrid, you're combining them all, right? They're still in that same arm, and then you're going to be determining whether or not, it was effective. From my perspective, seems new. I could be wrong about that, but that's what the evidence is going to show, how effective that is. And then we'll compare that to these completely virtual arms, these completely in-person arms. And then now we'll have a whole set of these hybrid type of interventions that are going to sprout out that we'll have to be able to determine their effectiveness too.
I think that's a really good question. I mean, our clinical trial initially started by telephone, so we didn't have to pivot in that regard. It was meant to be that way because we wanted to reach people who were, well, one, were cancer patients and didn't need to be interacting with people and exposing themselves to infection while they're undergoing treatment and recovery. But it was also the case that, you know, we wanted to be able to reach people who maybe didn't have transportation to be able to come in for an intervention, or who live in very remote rural areas. So the format we were testing was really designed to do wide outreach and making sure we were targeting underserved populations. I think that we, you know, initially, I guess some people were doing online or virtual types of interventions, and perhaps they were fairly good at it, and most of us were awkward in doing virtual types of interventions. But I think we have been forced, right? We've been pushed forward to have to learn how to do that. And so I'm hoping that those efforts are more effective, more efficient as well. I think I will continue within a few studies, continuing with the virtual format and survey format. But I would love to get back to face-to-face interaction and education, because I think that is of great value also for many underserved populations who may not be so keen on participating, you know, in the virtual world with strangers. And so that personal interaction is still really key to working with underserved populations, I think. I'm not sure.
Yeah, I think the ability to do things virtually is really just skyrocketed from this experience. And one of the studies I'm working on is a type 1 diabetes study, and we've been able to recruit nationally and mail people the 24-hour glucose monitor, and that's really improved the representative, you know, geographic representative nature. You know, it was from Chicago, which is a very diverse area, from University of Illinois Chicago, but being able, they were sending it to like way corners of like Texas and like stuff like that, which is super cool. And in our sleep apnea study, we've recruited participants from like around Blanding, Utah, like really Four Corners area, you know, like, so it really improves the reach for our studies to rural areas. So I think it's very positive. I hope that reviewers will also see it that way. We've already gotten some reviews back saying, we wish you'd bring people in, and you're like, really? Like, so, and then, you know, in terms of the quality of our studies, like the RO1 that I'm finishing up, I'm going to be underpowered. I mean, and I could stress about that, and sometimes I do, but then I also realize that, like, so the whole world is going through this, so we'll just do the best we can till we run out of money, and that's all we can do. You know, I mean, everybody who's in person is having the same experience. So whether this is going to be a bunch of failed studies, I mean, in my opinion, I've never had a failed study. There's always something I learned from it, even if the hypothesis is not supported. There's usually something interesting that can lead me to the next investigation. So I'm sure there will be something that can lead us to the next investigation, even if it's not powered for what we initially thought.
I think the question around the virtual in the past was representativeness, right? So selection bias. These people are often different than people who sign up for online studies, let's say, are different. Is that representative of the general population? But I do think now that argument, you could argue, may not be as strong anymore, as more and more people find this to be an acceptable way to interact and engage. And it's not super elite or super, you know, people of middle class or all the other, you know, predominantly white that, you know, might use that platform to participate in a research study. We'll find more diversity amongst the people, the denominator, right, of people who are using this. And so therefore the numerator isn't as so selective, but, you know, we'll see about that too.
Any other questions from the audience?
I was going to say, I think that's a really great point about the increasing like virtualization of minority communities, minoritized communities. I think, you know, we're seeing that in different pocket communities. And I actually just reviewed a grant where someone was actually arguing that certain minoritized communities are using that as a way of connecting with people across, geographical boundaries all the time. And so that's actually the most appropriate way of reaching them for outreach. And I thought that was a really interesting argument. I think that right now that may definitely be the case for some communities. So it will be interesting to see what was that?
Is it the critique, getting the critique on grants that low-income people do not use mobile devices just drives me nuts, because that's the way that people access the internet from low-income communities. And it just it's so ignorant. And I even resent that I have to have a line in there about how common cell phone use is as the main way of accessing the internet. But hopefully we won't have to waste our grant space on that sort of comments anymore.
Yeah, hopefully not. That's exactly right.
Right. People might not have a car, might not have a house. They have a cell phone, no matter the SES level.
So just to ask clarifying questions to that. So I'm in a process of developing a K where I'm making the case that my intervention should be virtual, because we don't know if the world is going to explode tomorrow. And then also that's, like all of you have said, people have access to the internet on their phones, et cetera. So is the idea to include a line, like Kelly mentioned, to make the case for why the design is that way? Because I am going to be submitting this to reviewers that kind of using Dr. McNeill's language, that she's old school and prefer things to be in person. So I'm just trying. So in terms of submitting grants in this age where we're not really sure what normal is, and we're not going to know what normal is for quite some time, and planning for interventions that kind of speak to that would be somewhat using a virtual format until we figure out what's going to happen. Like, how do you balance that in the proposals that we're developing right now?
So I'll answer this to say, having a cell phone that you use for what you want to use it for, and the notion that you're going to use it to engage in research, to me, are different. I still think you have to demonstrate that the populations that you're working with are willing to use that device and that medium and that mechanism of interaction for research. And in several areas, that is true. I mean, people have done physical activity studies in low-income populations and demonstrate great uptake of the intervention in that population, or smoking cessation studies where the counseling is literally via phone and you can demonstrate. But just because you have the device doesn't mean that you're willing to use it in that way. So you still need to make the argument that while the proliferation of the device is there, that the engagement of the population that you want to work with using that device, I still think you have to make that argument.
That's a really good point. And I also think that how you're interacting virtually with your research assistants is also going to matter. So if it's a lot of reading, right, it's like, what are the literacy levels? Also in introducing apps, what is the computer literacy? Even if you're using your phone for the internet, what is the literacy of the population that you're trying to target for using that in research, and to be able to read the information, do they have the skills or the literacy levels to engage in that manner? So it's a highly interactive, there's a lot of questions there to consider.
And then in terms of NIH, the reviewers are actually told not to consider the pandemic in the review process. And so, and as I participated in grant writing coaching groups this year, we really advise trainees, if they're going to talk about the impact of the pandemic or that sort of thing. I mean, you could say a line kind of like something like the result of the COVID-19 pandemic was a major increase in the use of telehealth and acceptability telehealth, or that sort of thing. But you don't need to say the world could shut down again or that sort of thing, because it actually comes off very stale. By the time the grant gets reviewed, the world is very different, and so even talking about all the shutdowns related to the protests and that sort of thing, by the time it gets reviewed, it's 6 months later. And so you don't really know what you'll be dealing with. So you could just say that it's increased the acceptability to a variety of, acceptability of telehealth medical care, that sort of thing. And everyone can agree with that, no matter what's happening in the world.
Thank you.
Any other questions from the audience? I did have one thing that came to mind. It was about moral fatigue. And I was wondering where you felt like you experienced, if you experienced moral fatigue when doing your research. And I know a couple of you touched on this a little bit, but this idea is very interesting to me. Like, how did you experience it while doing your research? And then how have you dealt with it? Has it gone away, or are you still dealing with it?
I'm personally not familiar with that term. Maybe everybody else is. I don't know if you want to define it. Moral fatigue. I've not heard that before.
Oh, sure. Sorry. So moral fatigue during the pandemic, I heard it talked about a lot as like this idea that you just get so tired of making decisions that are considering the dangers of the pandemic and how it's affecting people, that you experience a fatigue that's like a long term. So I didn't know if, like, while you're researching, if, you know, over the course of having to make all these decisions about pivoting and how changing what you're doing in your research is going to affect the outcomes and how it's going to affect the populations you're working with and how it's going to affect your team. Like, did you experience something like that, like a long-term fatigue? I think it goes back a little bit to the slide with the lemons and the guy, you know, getting pummeled. That's kind of the concept. Does that make sense?
Yeah, no, I mean, yes, it's a short answer, right? It wasn't just the fatigue of the science, it was the fight with my institution on top of that for making the case that said that, you know, if lab-based science is open and clinical trials are open, that engagement with the community needs to be, you know, sort of open as well. And I drafted many proposals. I felt like I was like a policy writer, like drafting policies, how we were going to minimize contact, how we were going to keep ourselves safe, what COVID procedures we were going to follow. We were going to check the threat level in the county and compare that against the city. We're going to limit the number of people to a small group size versus a large group size. I mean, I was in the weeds in like these kinds of proposals. Then I would present them to the leadership. And they're like, they just didn't want to say yes, so they didn't want to be that cold. So they would make you actually go back and like refine it, and you know, and then you're spinning your wheels thinking that you're actually trying to, you know, solve this problem. Where in the end, you know, really it was the COVID rates in the community that just weren't going to allow it to happen from their, you know, perspective. And so the frustration, I remember speaking with a senior leader at one point, and I'm a pretty like, you know, you tell me something, I'm always trying to problem solve. I had no problem solving left in me. I actually showed my face. Like, it was not a poker face. It was really clear to this person. I had it. I was done. Like, you know, and so they slightly scolded me, right? To then tell me that, you know, basically kind of instead of looking at me like you're pissed at me, you know, kind of go back and go try again kind of thing, right? And so I was mad in that instance that I wasn't showing enough professionalism. So all of the decisions and that's why I said in my presentation, I kind of gave in, I kind of gave up. It was important to almost resign myself to what was happening and work in that context versus this constant fight and battle that I was having. You know, it was exhausting, let alone any decisions that I was making for my research studies.
Yeah, I mean, we've all experienced fatigue, you know, and just, I think the biggest issue that I thought about was, you know, the feeling like, how can we think about doing these in-person mechanistic studies of healthy people when people are dying of COVID, you know, protests are happening, you know, there's so many important and critical things happening in the world, and how like, it felt very insignificant during that time. And then, you know, as a lab, we did get some pilot funds to do some COVID related research that felt meaningful. And that gave us all kind of a boost to work together on doing some qualitative research in that area. But also, I just thought about protecting the people that work for me too, in terms of keeping them safe and also keeping them active and employed and keeping our, you know, working on mental health and that sort of thing. So trying to keep our keep our lab going. And that gave me meaning, because if we have a study, we all have jobs, and that's something that's worth a lot. So that's where I thought about that. But it's, I think it's just the ongoing nature of this, that it's always changing. It is exhausting.
Definitely exhausted. So the clinical trial was, there was no need to stop it as long as we were able to recruit participants, but it was the adjusting everything as to how we were doing it. Also adjusting, how can we work with the clinical sites to refer participants to our study? That was very, very hard for us because they were swamped. They were exhausted, and that was the main pipeline for recruitment in our studies. And so always trying to brainstorm, how can we do things differently? How can we adjust, right? It's like, it was constant. And then as the time was running out on our grant, because we were told, you're not going to get an extension on your grant, you're not going to get a carryover on your grant, use it up or lose it. And so we thought this study is too important. And it was currently, even though it was targeting the issues around the topic of cancer, it applied to everything. What the mothers were learning in the program generalized to the pandemic. So it was beneficial to them in a variety of ways, other than just dealing with their cancer diagnosis. And so that was exhausting to figure out, how are we going to continue this, and asking people for money and getting a no here and getting a no there. And like, no, we're not doing that. And then finally getting a yes from our VPR to say, yes, we'll provide that support that you need to continue. And then just out of the blue, money coming from other unexpected places was a godsend. But I'm exhausted. I am so tired. And the writing, the time to write is on the side, because it's like we're juggling so many balls just trying to get the clinical trial completed, and then also all of our other duties as professors, as you all know. The job is exhausting. So maybe not morale in terms of safety, because we were already working by telephone and we were able to shift to a virtual format, but exhausting and trying to keep tabs on our people and making sure they were okay, and making sure we were being sensitive to them, which, sometimes you get so busy, like you don't pay attention, but there were, so glad our program manager was excellent at that and keeping tabs on how people were doing and such, and saying, hey, we need to pay attention to this. So.
And don't you miss the part of science that is the enjoyable part, which is, interacting with other people? For me, it's interacting with other people, learning new things, exploring my curiosity, getting excited about ideas. And like all we're talking about is being managers and putting out fires, and it's terrible. This isn't the job that I thought I'd have.
Yeah, I was just kind of thinking about that. Like the flip side of this is what you've all alluded to, is that this did actually present opportunities for increased collaboration, new opportunities for team science. So even though there was this fatigue associated with it, it also kind of created new networks and new opportunities. Can you speak to that before we end, so that we can flip it? Let's end on a positive note about what had happened during this pandemic.
So one of the things in our study was that we started with a narrow regional focus. So we were focusing just in the Paso Norte border region. And when the pandemic hit and it became more difficult to recruit participants, we started talking with our collaborators from the UW, and they were like, we need to expand, right? And we have these contacts at these other cancer centers who might be interested in assisting, and who would have large proportions of Hispanic women that they serve. And so we started making connections with UT San Antonio, and we were talking to folks at UNM and elsewhere, and we ended up making some really good connections. And we actually connected with Mays Cancer Center in San Antonio, who serves a wide area of the border region. And so that was phenomenal for us. And we hope to continue working with them from this point forward. So for us, that was a huge benefit.
and I noted in my presentation as well, just an increase, a astronomical, from my perspective, increase in people interested in cancer disparities. Like I said, whether or not it's fly by night or that they'll be doing that long term remains to be seen. But I became really, I was always, but I really became a disparities generalist during this time, where anybody could kind of talk to me about whatever their disease site was and try to have a health disparities sort of perspective to it, right? So the methodologies that we bring to this work of community engagement and designs that have community input in them, and health literacy around measures that they're going to use, focus on recruitment and retention, and making sure that those are culturally appropriate. So from brain cancer to the leukemia people, the lymphoma, myeloma folks, like all these people who never did disparities work before, knocking at the door all day. This new RFA came out. And in fact, lots of funding agencies required that you kind of have some statement, something that you were going to say about what you were doing. And they were at a loss for words. Like, what should we write? What is, this is the paragraph that we wrote. Can you edit it and see, if it's right? So I have a whole bunch of, hopefully, new grants that will get funded in this area. If not, people will revise them. But it's been a great time for an explosion of interest in disparities. And that doesn't include the fellows that are all into it, and they want training in health equity. And even though it's technically part of their GME accreditation, it's really like a one lecture that I usually give a year. No, they want a full course. People are going to get 10 PhD degrees. Like, it's just a whole other, like I said, explosion of interest in training and expertise in what we all do. So I always said, I was like, oh, I became like one of the most popular people in my cancer center all of a sudden, and hoping to increase the pipeline and increase the number of other cancer disparities researchers that other faculty can call on as partners, as collaborators on these research efforts. I hope it stays. I hope this interest remains, but we'll see about that too.
Great.
Those are both great ways to expand your research during this time. I mean, and I think this just led to more flexible responding in terms of thinking about recruitment and how we do our work as well, in terms of being able to recruit outside of our geographic area and the use of telehealth, and that'll improve the reach and representativeness of our studies.
Well, thank you so much to our 3 panelists, Dr. Palacios, Dr. Barron, Dr. McNeill. This has been really, really insightful and helpful, and just really appreciate your input today.
Thanks for having us.
Thank you. Our pleasure.
So I will be sending a very short 3-question follow-up webinar evaluation, and I hope everyone has a wonderful rest of their Wednesday.
Thank you, everyone.